All right. So just to kind of go over in the last couple talks, we went over basic pacemaker programmability in like the VVI mode, mode selection in general. We talked about the conduction system of the heart. We did a 12-lead interpretation of MI through Julius, who was a fantastic presentation there. Looking forward to seeing more of that for sure. And then Jared picked up with SVT discrimination and basic functionality with ICDs. So I think we'll probably just take a little bit of a step back here because I think we're getting into some complex subjects and just go over some more general pacemaker functionality, specifically focusing on the electrical concepts behind pacing. So like always, I love to have input. So if you have any questions as I'm presenting, feel free to chime in. If you raise your hand on Zoom, I can't actually see it. So just come off mute and ask away. And, I really appreciate any participation you have. So we'll go ahead and get started. Let's see here. Okay. So I really quickly wanted to kind of browse over the different kinds of leads that you may come across on the market. So you have your passive fixation leads, which you may or may not have come across. These are great. They tend to be less traumatic to the tissue. They have maybe a little bit of a safer patient profile, especially with atrial leads, if there's a place to put them. So if they still have an intact atrial appendage, there's a lot of trabeculation, and these little tines can actually engage in the atrial appendage and just kind of sit right there. If they've had those clipped through surgery, it's a lot harder to place those, and I wouldn't recommend necessarily a passive lead in someone who no longer has an appendage, but I'm sure it's been done. Here are epicardial leads. So these, looking at it, I believe this is the Medtronic style. Here is manufactured by Great Batch. This is more of an active fixation helix, but these are actually done by either doing a window or doing a full open heart surgery and attaching these leads to the epicardium of the heart. So the way it functions is it actually captures from the outside in. Here is another epicardial lead. You have your active fixation leads. This one is a retractable helix. You can see the helix has been retracted in this case. Some come with a active helix that's actually already out. But just to give you an idea, these are most likely what you'll see a lot of times. So the way these function is you have your tip electrode, and then you have a at the distal end here, and then you have a more proximal electrode, or you use the can as your anode. So your cathode will be your tip typically, and then your anode will be the source to where the the electrons basically flow. So in this case, here's your ring electrode. You'll pace from the tip, the cathode, negative, and then it'll move to the positive. I just want to kind of demonstrate here, older leads didn't actually have bipolar capability. Bipolar is relatively new in the last couple decades, but conventional leads are mostly bipolar for the most part now. So in this case, where is the anode located in bipolar pacing? You have your cathode, your negative here, and then your anode will be at your ring electrode, or if it's say like an integrated lead like you have with Boston, it could be your conductor coil. So it's just going to be a little more proximal, but we're not going to the can. If you're going unipolar, then it would be the tip to the can being the positive here. And the reason why I'm saying positive, negative, why does it matter? It's just how you complete the electrical circuit, basically. So the electrons are going to flow from a negative to a positive. In a unipolar lead, you can see here, it's much simpler if I didn't cross through it. Just a single core to it versus the modern bipolar. They used to be side by side. Now they actually wrap the ring electrode around the outside, separated by an insulator right here. It's kind of interesting to see because you see that the anode, the ring electrode, is actually more exposed in some sense. It has less insulation. So typically when you see bipolar leads failing in modern bipolar leads, it's the ring electrode that is failing. In those cases, you can actually program unipolar to circumvent this option here that could be failing, which we'll get to later on. So what are your goals for cardiac pacing? So the real reason, the the real motivation behind pacemakers is we want to make sure we capture, obviously, because if we're not properly depolarizing the heart, then what are we doing? And then we want to sense. So modern pacemakers, obviously, we want to sense the intrinsic activity that's going on in the heart and inhibit pacing accordingly, and or track and or any number of things we kind of discussed when we talked about pacing modes. So these are affected by many factors, basically your ability to capture, your ability to sense. You just have the core electrical concepts that can affect it, but you can also have impedance, which is a relation of the leads you're using, as well as the patient. Parameters you've programmed, the patient's own cardiac activity and baseline. So there's going to be a lot of things that come into play here when you're evaluating pulse amplitude, pulse width. When you're evaluating your ability to capture and sense. And I guess what I'm really trying to tell you here is that you're not going to find a catch-all for every single person. Your parameters will differ from patient to patient. It will depend on whether or not you're trying to extend longevity or ensure capture. And there's a lot of things that come into play. So we'll get to them. So capture is the minimum amount of energy that is required to consistently depolarize the myocardium. So when you're assessing a capture threshold, it's just whether or not you can evoke a response in the tissue consistently. And I guess things to keep in mind here is the capture threshold is not a constant over time. It can vary, between implants and follow-up. It can vary between a number of factors like heart failure. So just be aware that you're not going to have it's not a simple answer of what is capture and what is not, especially because we're trying to conserve battery over time. So when we're determining capture, we're looking at a number of different factors, specifically the amount of energy or the amplitude, it's actually voltage, and the total time that you're giving that voltage. So you may have seen this curve. I'm sure, Elvis, you see it when you're looking for studying for the IBHRE, but this is your strength and duration curve. And essentially, this is showing you that everything, it's getting away from me here. Everything below the line here is not sufficient time or voltage to capture the heart. Everything above is. And the reason why I kind of wanted to display this chart here for you is that it shows no matter how long you're giving giving a pulse for, there's a certain period of time, it doesn't matter how long you give energy, it's not sufficient to capture the heart. Versus voltage, there is a greater association between the amount of voltage given and ability to depolarize the tissue. So when you're assessing whether or not you capture, you may be assessing, well, can I bump out my pulse width to try to maintain battery longevity? At a certain point, it's not going to do you any good. So just keep this in mind when you're trying to program an optimized battery, which we will get to here. So one of the things we talked about here is acute to chronic thresholds. So what you may see at implant is that your threshold could be, for example, 1.2 volts, but later on at follow-up, the threshold is exceeded and maybe you're not actually capturing anymore. That is why typically we set a nice safety margin, which we'll get to, but just things to keep in mind as you're navigating and implanting devices. Is that, initial implants don't necessarily determine long-term thresholds. So I kind of wanted to visualize this for you, and these aren't, given numbers, these kind of depend patient to patient, but it's not unheard of to have thresholds that are elevated above 3 volts during initial implant. I especially see, and I don't know, what you other implanters see in the field, but for atrial lead placement, for example, when you really screw in that active fixation helix, you may see the threshold even go up to 5 volts. As long as your impedance and other numbers look good, those are usually a recommendation to give it time, because contemporary leads use steroid elution, which I'll show you here on the next slide, but it really tends to bring down the threshold. So you'll see this initial rise in threshold associated with a current of injury, which we will talk about later when we're discussing implants. But you'll see this initial rise after letting it set in for around 20 minutes or so. You may see thresholds come down to more appropriate numbers. But then at follow-up, you may see that those thresholds have risen again up to 2.5 volts. So just things to be aware of. So when we're talking about acute to chronic thresholds, steroid elution has really changed the game as far as our long-term outcomes and thresholds. So here is a slide kind of indicating the total amount of time, and then you're looking at the total amount of voltage needed to capture the heart. And an implant, we're at 1 volt, great threshold. But as you see over time, before steroid elution, you tend to see this sharp trend in threshold over the next few weeks. And then it slowly tapers back down to a baseline, but you still see an elevation over implant. With steroid elution, it actually helps to prevent scar building up around the electrode.
Hello.
Yes, sir.
Good evening.
Hello, good evening. Oh, sorry, I thought you had a question there. Welcome to the call. Yeah, so we were just talking about modern leads and steroid elution. So you're not going to see this, and you may see it still in your textbooks when you're studying, but you really don't see modern leads really having such a sharp upward trend in threshold over time. And that's just because of the steroid elution that we see in modern leads. All right, so what can affect thresholds? So any number of things. It can be activity, it could be the posture. So you may evaluate a patient on the table. And then later on, when they're standing up, you may see that the threshold is different. That could be any number of things. It could be a vector difference, time of day, comorbidities, heart failure, whether or not they've eaten, whether or not they've taken their prescription drugs or any kind of non-prescribed drugs, and then progression of diseases over time. So things to keep in mind when you're programming a patient. Just because you assess the threshold to be 1 volt, you don't necessarily set them at 1.25 volts ongoing with a permanent setting, because you could be capturing now, but later on they stand up and walk around, and now all of a sudden their threshold rises to 2 volts. Well, you no longer have enough energy to consistently capture the heart. And in patients who are dependent on a device, that's not ideal. So things to keep in mind there when you're assessing. So that is why we have a nice safety margin. So modern safety margins, we do around 2 to 1 or 3 to 1, or we use some sort of automatic capture algorithm to assess that. Abbott uses auto capture. I don't know the names for the Medtronic ones, and Medtronic experts, feel free to chime in. But essentially, the device does it for you, where it assesses what capture and non-capture looks like, and then determines what the threshold is, and then gives it a nice margin over the top. If you're not able to do that, then we just merely say, for example, the threshold is 1 volt. We may set the output at 2 volts, so a 2 to 1 margin. But the big thing is we're trying to extend the longevity of the device without compromising the safety for the patient. So when you have these fluctuations, obviously it could not be ideal. Really quick too, while we're on this subject here, feel free to contact any of us when we're trying to optimize the battery. One thing to keep in mind is that not every manufacturer has the same battery makeup, and the batteries don't always function the same based upon the circuit board attached to it. So, for example, Abbott devices have what's called a voltage doubler at 2.5 volts and a voltage tripler at 5 volts, right? So if you can, we discussed the strength and duration curve here. If you can, it's a little more acute, I guess, like that. If you can keep the voltage underneath 2.5 volts, you'll find that the battery lasts considerably longer, because it doesn't have to, the circuit board doesn't have to basically double the amount of energy being drained here. So, for example, if we assess the threshold at 2 or 3, say 3 volts at 0.4 milliseconds, but the threshold is going to be, for example, at 1 millisecond, it's only going to be 1 volt, right? So in this case, it's actually advantageous to program the patient 2 volts, if I can do it with my right hand, at 1 millisecond. And that sounds counterintuitive, right? Because you're delivering energy for twice as long in this case. But because you're not hitting a voltage doubler, you're more efficient in your output. Once again, this is all kind of a deeper dive, but if you ever have a patient that comes in and they're programmed at 5 volts at 0.4 milliseconds, it may be good to reach out to one of the device experts and ask them how you can optimize that so you have as little current drain as possible and extend the life of the battery. It can make a difference of 1 to 2 years sometimes. So it can be very impactful for our patients. So next we talk about sensing and the threshold behind it. So similar to what we talked about with voltage, but the inverse, it's the smallest intrinsic signals that can be consistently sensed by the pacemaker. So there's a couple ways you can do that too. The device itself can actually measure the amplitude of the sensed R wave or P wave, or you can actually manually decrease down the sensitivity, which we'll show here. So here's a good diagram. If you can see here, here's your R wave, here's your T wave. This device would effectively be double counting because the sensing threshold is set so low. So what we'll slowly do is we will raise this fence here until it's enough to consistently sense, but without over-sensing this T wave. And that will be your new sensing threshold. They may double it, or that'll be your new sensing threshold, and then you'll actually set your setting at a 2 to 1. So in this case, this may be 1.5. You really have to understand how tall these R waves are before you set your sensing. But in general, if you have 2 millivolt R waves, you're really going to have to set your sensing quite low. 1 millivolt, if your R waves are 12, then your sensing can be, a lot higher threshold at 6 millivolts. In general, the lower the fence, the more sensitive the device is. So it's kind of an inverse relation. So if we say we want to lower sensitivity, we actually want to have a lower value as well. Does that make sense? Hopefully everyone's still on the page here.
Sorry, can you kindly repeat that sensitivity and sensing?
Yeah, so
it makes sense.
Yeah, and just to go over it, sorry, really quick, because you'd asked. Basically, your sensitivity threshold is this fence here, and that's the best way to kind of picture it as a fence. And your goal is to not see what's happening here with the T wave, but you still want to see what's happening here with the R wave, right? So you have to raise your sensitivity value so that it's above the T wave. In this case, if you have your sensitivity set at 1.25, you are very sensitive. So the device will see every kind of signal that is above 1.25 millivolts. In this case, that's both the R and the T. By raising your sensitivity threshold, or by raising your sensitivity program setting, you can effectively miss what's occurring here. You don't oversense the T waves, but you're still properly sensing the R waves. That way the device can respond accordingly and inhibit pacing when it needs to, and pace when it doesn't. Things to keep in mind though, PVCs tend to be wide and ugly. They tend to be very tall. So if you measure a PVC, it could be 12 millivolts, but their intrinsic could only be 6 millivolts. So you don't want to program based on PVCs because you'll set your sensitivity setting so high that you never actually see the intrinsic conduction. So just things to look for there. Does that make sense?
Yeah.
Yeah.
Very clear. Thank you.
It's fine.
Okay. So we then talked about safety margins with capture. There's also a safety margin with sensing as well. And we still use this 2 to 1 idea that you see with capture as well. So in general, if you have an R wave that's 6 millivolts, you may set your sensing at half of that. So 3 millivolts for your R wave. And that just ensures that you may be able to sense when those values change. Just like capture, sensing can change over time. It can be positional, it could be disease progression, any number of things. And if you just set it for 5 millivolts, for example, we may be under sensing when the patient is lying prone, which means we could be pacing either into vulnerable periods or pacing when the patient doesn't need to pace, which is obviously not ideal. So just things to keep in mind. Everything in pacing in general is a 2-to-1 a lot of times. 2-to-1 capture margin, 2-to-1 safety margin. When we talk about implants with leadless, 2-to-1 plays a major factor as well. So, all right. So now we talk about impedance. So impedance is one of the best ways to evaluate your lead integrity. And basically, impedance is the measure of resistance to the flow of electrons within the circuit, right? And what the value of the impedance is, as long as it's within reason, generally between, this case it said 300 and 1500, but 200 and 2000 is also, what you'll see. Generally, you'll see the impedance somewhere in this range. If it gets below, then we're in trouble. But the actual number itself matters less than the consistency of the impedance. So if you are consistently, man, this is really click happy today. If your impedance trend is consistently within like around 450 ohms and it stays this way, that's generally a pretty strong indicator that the lead integrity is going well. If you see your impedance trend over time having this slow rise, or you see sudden jumps in impedance or drops in impedance, that can indicate that we have a much larger issue to address. So here it's kind of describing like the factors that can influence impedance. In general, what we're looking for though is changes in impedance over time, because a lot of these things are controlled for. So when we talk about impedance as an indicator of lead integrity, the big things, like I said, we're looking for is drops, jumps, or slow rises or falls in impedance, indicating possible issues. So I think the best way to describe this is actually by using this hose metaphor that's been used many times. But basically, if you use a garden hose, your normal resistance is the amount of friction that the water has to leave this hose, right? So you have this natural friction force or natural resistance on the line as the water is trying to leave, right? But if you see over time that when you turn on the water, you're having less water flow out the tip or less current, that indicates that there's less resistance somewhere in the line and there could be a hole in your hose. Inversely, if you open the hose and not much current comes out at all, but it's a high pressure system, that could mean that there is a knot or a kink in your hose, which could mean that there is damage to the conductor itself. So I kind of use this visualization. I think this is really a good example of a conductor failure. Man, I'm going to use my keyboard, of a conductor failure versus you have insulation breach here. So either one of these can affect the device's ability to pace, can affect the device's ability to sense over time, and the things to watch out for. What you'll see sometimes with conductor failures is you can have what's called make-break signals, where there's actually a separation, occasionally, say when the patient stretches or when the lead is stressed, causing it to not be able to capture. But then when it comes back together again, when these metal pieces, unite, it could act normally. So what you may see occasionally is inconsistent capture, but when you measure the impedance, it's within range. So those are the reasons why when you look at those impedance trends over time, if you see a bunch of random outliers here, this could indicate that we have some sort of conductor failure and we need to monitor and or revise this lead. Everybody on page there? Perfect.
Yeah.
Okay.
Move
so
on.
I think this is a good example here. Basically, this is a patient came in for a gen change. And when they evaluated the lead impedance at the time, it was 1,800 ohms. So they did a chest X-ray, and if you look at it, there is just a clear issue going on. Now, it's not always this clear, but in general, if you see a chest X-ray and there seems to be damage to the lead, and there's a trend in the impedance, that indicates that you may need a revision. These are all things that are better to know before you actually have the patient on the table. But I think that one practice that I always do personally for gen changes is evaluate the lead integrity. And then while I'm monitoring the patient, have them do different isometric exercises like stretches, any kind of resistance, windmilling their left arm, things like that. And that's kind of evaluating if there's some structural damage. We may see it registering as noise on the lead. We may see it register as non-capture, any number of things, but it's all good to evaluate while the patient's in for a generator change. One of the most common, issues with generator changes is infection. So if we can avoid having to open the patient up a second time after we just changed the device out because there's some issue with the lead. So I advise to evaluate the leads early and often. And then just basically assessing integrity. Obviously, you're going to be looking at trends, and then you're going to look at how the changes have actually happened. Have they been sudden? Have they been gradual? All things to keep in mind. We had talked about pacemaker functionality, but just to go over it, because I think it's really important for everyone, just remember pacemaker functions with ICDs will inhibit therapy as far as shocks, but will not affect the pacemaker. With a pacemaker, when you apply a magnet to it, it will cause it to pace asynchronously, either VOO or DOO, depending on it's programmed. And then it's also usually used to be an indicator of battery life. So in Abbott devices, if you place a magnet over a pacemaker and it's 100 beats a minute, that means that it is generally a pretty good battery and they have some more life left on it. As you get closer to 85 beats a minute asynchronous, that indicates that the battery is nearing what's called ERI, where it needs to be replaced. So you can use that to evaluate, as well as using magnets during surgery so that you don't have to permanently program the device. As long as the magnet is over it, it will be in its magnet mode. Once you take the magnet off, it reverts back to a non-magnet mode. Everybody cool on all that as far as the electrical concepts? How does everyone feel there?
Yes.
Yeah, it's good, mate.
Yeah, that's good. Thank you.
Okay, sounds good. So moving along to pacemaker timing cycles, this is kind of, if you don't deal with pacemakers, it's kind of a difficult concept, but I think it's easiest just to remember that pacemakers are just a bunch of little clocks running at once. And when an event occurs, it starts or stops a clock, and that essentially dictates the behavior of the device. So when we talk about timing cycles, we just say, when are those clocks starting? When are those clocks stopping? Refractory periods is when the device is able to basically observe a signal, but it doesn't respond to them. Blanking periods are when the device is completely blind to any kind of signal that could be occurring. And then alert periods is when the device is able to sense an intrinsic activity and respond to it appropriately. So just keep that in mind as we jump into this. So the timing cycles are broken up between atrial and ventricular timing cycles. You have your initial AV delays, which is the time between an atrial event and a ventricular event. Specifically, for example, a paced AV delay is a time between a paced atrial event and a sensed atrial event. Generally, you'll see your paced AV delays longer than your sensed AV delays. Part of that is because by the time that we actually, sense an atrial event, that P wave has already been partially occurring. So we don't need to necessarily give as much time before we pace. We want to have enough time to have adequate filling, but we don't want to wait so long that they lose that atrial kick or that 30% of their output. So that's why you'll see sensed AV delays generally a little shorter. Rate responsive AV delay, that's just used to kind of act like a normal healthy AV node. As your exercise increases, you may see the natural time between a P wave and a QRS complex gets shorter. And that's just basically, this is us trying to copy that natural occurrence there. Shortest AV delay is how short it gets. So we'd spoken in the past about VIP. I just want to kind of go over that briefly. So essentially here, we're just trying to visualize how the AV delay functions. In this case, we have an atrial sensed event occurring here, which starts our AV delay. If you remember, our sensed AV delay in this case was 150 milliseconds, so we'll call it 150. I'm not going to count out the boxes here. It waits its full 150. No ventricular event occurs, so it paces. This, we wait to the next timing cycle, and atrial clock is started once again, sensed AV delay. When this atrial event occurs, it waits 150 and it paces. And it will just continue to do this until either a ventricular event comes through. If a true ventricular event comes through, it will then withhold the pace and reset the clock. Same thing, in this case here, you see a paced event in the atrium, and then you see this delay in the ventricle is reset to 180 milliseconds. So you see a little bit longer delay. Does everyone kind of understand the concepts behind this? We've talked about VIP in the past, so this is a bit of a backtrack for some of you all, I'm sure. But basically, I'm just trying to demonstrate how the device regulates the atrial and ventricular events. And my wife just walked in, so. If an R wave is sent, so as we spoke about here, we have a paced atrial event. It sets the paced AV delay, ventricular event paces, so on and so forth. In this case, we have a sensed atrial event. It sets the sensed AV delay, but because an intrinsic ventricular event comes across before this timer runs out, it withholds the pace and then resets the timing cycle again. Same thing occurs here. And then here again, we have an atrial pace. A sensed ventricular event comes across, which resets the timer and it withholds the pace. Basically, the device is kind of responding appropriately. Next, we have PVARP. So you may have heard of PVARP, or post-ventricular atrial refractory period. And basically what that means is that after a ventricular event, the atrium is put into refractory and doesn't respond to any kind of sensed event that could occur. And the reason why we have PVARP, the reason why it exists at all, is a risk of retrograde conduction. So we talked about the AV node in the past and the intrinsic conduction of the heart. But one thing that can actually occur is this AV node, even though it passes the electrical signal from the atrium to the ventricle, things can actually run backwards through that node as well and repolarize the atrium. So with a PMT, what you can actually happen here is an atrial event is sensed. The device, I'm going to go back my mouse here. The device senses it, it paces in the ventricle. But because we don't have, because the atrium may be in refractory for whatever reason, or say this is a PVC, the electrical impulse runs retrograde into the atrium. It is sensed again. The device sees it, interprets it as a true atrial event, and then paces again in the ventricle. And this creates essentially an endless loop tachycardia, but with the pacemaker being the accessory pathway. So when you talk about SVTs or AV NRTs, things like that, this is your pacemaker acting as the accessory pathway by essentially V-pacing, sensing the retrograde event in the atrium, and then pacing on and on at a high rate. So with PVARP, what happens is when we have a ventricular event occur, the device effectively ignores anything that occurs in the atrium for a certain period of time. In this case here, for example, our PVARP is too short. We have a PVC. This causes a retrograde A, and you can actually see this P wave right here. The device sees it as an atrial event. It then V-paces, which causes a retrograde A, which the device sees an atrial event, and it V-paces on and on forever. if we've appropriately programmed our PVARP, when you have a ventricular pace, the device is in refractory for this period of time here where it's not watching. It will miss this atrial event and will stop this endless loop tachycardia from occurring. So that's why it's really important that you program your PVARP. Everyone on page with that?
Yes.
Okay.
Move on.
Perfect. Next, that brings us to PVAB. So that's your post-ventricular atrial blanking. So basically for this is actually when the device is blind after a ventricular event. If you've inappropriately programmed your PVAB, what you may see occurring, like in this case, is double counting of atrial, or you'll basically see double counting because you'll be counting the ventricular signal on the atrial channel. This can essentially lead the device to, in this case, it said AMS, but it senses this as an atrial arrhythmia when this isn't an atrial arrhythmia. This is just a functionality of improperly programmed PVAB. So had this device had a proper PVAB, when this ventricular event occurred, either VPACE or VSENT, it will blank for a period of time, which will miss the atrial event being oversense here, and the device will no longer count this. So basically what we're doing with PVAB is we're trying to obscure what's happening in the ventricle on the atrial channel to avoid inappropriate mode switching. Things to keep in mind. Now, you don't want to just bump out your PVARP and your PVAB. That can actually just too far, because that can affect a number of things like your 2-to-1 block rate or your device's ability to track high rates. With ICDs, it can affect your ability to discriminate atrial versus ventricular driven events because you may be undersensing atrial events. So PVARP, PVAB, all these timing cycle programmings really come down to the specific patient, right? So if the patient doesn't have conduction, we would have short AV delays. If they do have conduction, we may have long AV delays. If a patient has very long retrograde, then we may set their PVARP at 330, 400 milliseconds. If the patient has no retrograde conduction at all, then you may shorten it to 175. And you know, it's less important to memorize specific numbers in programming, and more important that you analyze the specific patient and optimize the device for them. So these are the kind of cases when you can reach out to us to help you through this process and assess, you know, how to program appropriately. So here's a good visualization of PVAB and PVARP. They both will start at the exact same time. So your two clocks both start at the same time. However, your PVAB obviously won't extend as long as your PVARP. So you have your atrial pace event, you have your ventricular pace, which starts the PVAB timer and the PVARP timer. This effectively blanks out any kind of any kind of ventricular signal on the atrium with your PVAB. And then this will kind of obscure any possibility of retrograde or inappropriate tracking with the device. Same thing here. If you have an intrinsic ventricular event, when the intrinsic ventricular event is first sensed, that starts your PVAB and your PVARP timers as well. So just a way to visualize it. That brings us to our ventricular timers. So just like we had blanking in the atrium, we also have blanking in the ventricle as well. This is to avoid any kind of oversensing of the atrial pace, especially on the ventricular channel. It could be very detrimental to have to basically sense that atrial spike. What you could see occurring is the device could see the atrial spike, interpret that as a ventricular event, withhold the ventricular pace, and you could just have atrial pacing all day long with no accompanying ventricular pacing. So as a result, we tell that device just to cover its eyes for a period of time after we pace to avoid any kind of inappropriate inhibition of the device. So here it is visualized. We have an atrial pace. We don't actually see what's happening with the ventricular signal. This is just an EKG, but the device has immediately sensed a ventricular event and it withholds its ventricular pace. We see a VS here. The ventricular pace that would normally occur out here has been withheld, and this patient has gone without a proper ventricular event for more than 2 cycles. This can be, obviously symptomatic for patients, and it can be deadly if not programmed appropriately. So that's why these exist. Once again, memorizing everything about PVAR, PVAB, all these different things is less important than understanding why they occur and understanding that these devices are very simple in their nature. They're very intelligent at what they do, but they're very dumb in the fact that they can't really make executive decisions. So when we're programming devices, it's up to the programmer to understand what the specific patient's situation is, and then also appropriately programming the device so it responds to what it sees. Because inherently, these clocks just run, and the device responds based upon what it's observed. So programming your capture, programming your sensing, programming your blanking and refractory periods all play a role in how the device is able to respond and do its job appropriately. So in this case, we talked about blanking. Here is V refractory. That's just to avoid oversensing any kind of T waves or anything like that, and double counting of QRSs. So essentially, we don't need to have our eyes closed, but we need to not respond to it and call it a ventricular event if a patient has tall T waves. So that's really all I have. And I think that I probably could have explained things a little more clearly. So if you have specific questions, I'm happy to go through these and, answer whatever you may have. We also have other people on the line that can answer your questions. Once again, it's not about knowing every single idiosyncrasy of the device. It's just understanding how we can use the tools that we have to optimize a device for a patient.
That was really good, AJ. It's Jared here. Good talk, mate.
Oh, thanks. Thank you.
Just say again.
I said I think I need more coffee, but other than
that, just to go right back to the start when you were talking about lead design with the unipolar. I think it might have been your first slide, the tip to ring on your leads. I think it's 2 things that come to mind immediately, especially for in clinic and even during implant, to look out for is that if a patient does present with a high impedance at clinic in a typical bipolar configuration, as we say, tip to ring, then it's not all panic stations, because as you say, changing the pacing configuration or to unipolar tip to ring, and then if you find that the impedance is actually normalized, then you can isolate the issue to the ring electrode. So usually that doesn't necessarily immediately mean that, having to send the patient for a lead replacement. So if you do find yourself finding patients with a high impedance in bipolar, an acute high impedance, then it's always worth testing it in unipolar. And if the unipolar is okay, as I said, you can pretty much then isolate the issue to the ring electrode. If the issue is if you go to unipolar and the issue is still high, then the issue then typically lies with the tip electrode. So you are probably looking at lead replacement at that point, almost imminently.
I don't know about you, but I have seen some instances too where you can capture better ring unipolar. And in those cases, I think it's typically some sort of calcification or things like that on the electrode. Have you observed that as well, where ring is still an option sometimes?
Yeah, once or twice, but not a huge amount. I think you got to get lucky. But the other instance, which is probably worth bringing up, is especially at implants, especially maybe for an operator or even as the rep or the physiologist in charge of testing the devices. When it comes to if you think there's an issue maybe of perforation, again, we're going to be typically programmed tip to ring here. And sometimes if you do have lead perforation, then usually your tip electrode has come out perhaps of the myocardium. But because your circuit with the ring electrode is so short, you can still capture enough myocardium with enough output. And if there's ever an issue perhaps that you have perforated, then again, it's always worth programming the device to unipolar tip to can. And if you get no capture, then that is probably evident that the tip electrode is outside of the myocardium. So it's just a little tip there. If you do think you've perforated, program unipolar. And if you've got no capture, the chances are that your ring electrode is outside the myocardium. But you can be fooled sometimes in bipolar if you have perforated that you've still got capture, because it's such a small circuit with enough output, you can still capture around that ring electrode. So again, just something to be look towards, and can also be seen perhaps on if you measure your injury current, you may get a negative injury current as the current is moving away from the electrode. Mm-hmm. So again, that's another indication that perhaps you have perforated. So yeah.
Just for clarification to the group, when he's speaking about injury current, so when you were evaluating the unfiltered signal on the PSA or pulse sense analyzer we use during implants, injury current is basically widening of the QRS and or, like you may see like a T wave elevation as well from baseline versus like a narrow signal. So if you look over and your paced signal, you're still capturing, but it's very narrow versus maybe a wider signal here. That could mean that you don't have good tissue contact. In this case, he also mentioned negative. So if you see negative injury current from baseline, that's usually not ideal. You can be tricked depending on how the lead is setting against the myocardium, but in general, that just means that the electrical impulse is moving away from the tip electrode. Jared, that was a really good point. What you mentioned as far as capture. One thing that a physician showed me a number of years back that I thought was pretty cool, and I like to use for implants is just quickly going unipolar with the cables as you're implanting a lead, just to assess whether or not the unipolar impedance is higher than the bipolar impedance. So in general, your unipolar impedance through the electrical system should be lower. But if you've perfed into the myocardium, what you may find is that your unipolar impedance, because you're outside of the heart itself, is higher. And in those cases, it's always a good idea to pause and maybe assess the lead if you do see that. It's not always 100% specific. You can get false positives, but it's pretty, it's pretty sensitive as well. So you're more likely to get a false positive by having a higher unipolar impedance, but you're more likely to detect it in general. So just a quick trick that you can just do as you're assessing lead integrity, especially if during the implant, they seem to have put it into an unsafe location, like more anterior, as opposed to more septal locations.
Absolutely. I was going to follow up with what Jared was saying with the like ST depression as opposed to STEMI for your injury current. And you've got, obviously both of you have covered it really, really well. But the other thing also, if you've got like a half perforation, what we did notice in the patient is that with your sensing of the R wave, you can have like respiratory variations, can also have a fluctuation in the R wave sensing as well. So that could also be an indication that there is a slight perforation. For instance, if the anode has maybe sort of gone far beyond and the ring is still in the myocardium itself. So as you breathe in and breathe out, you might get some fluctuations in there. And we saw that with an ICD patient a while back. So, but the thing to look out for really is your obviously injury current. You get ST elevation, so STEMI. If there is a perforation going through, then you would get your ST depression really for the injury current. So look out for that. But also remember that the person, the implanter, could also reverse the pulse as well. That can also cause that as well. So watch out for that, especially for registrars who are inexperienced. Can also do that as well. So also make sure that you put the pulse on right when they're connecting it to the lead tips, the terminal pins. So. Yeah,
that's a good point. Fellows will do that, especially like people who are still training will just, so in general, for everyone, if you're doing, hooking up a lead, it's black to the pin and then red to the ring. But, we'll tell you in the case when we see a negative injury current. Perfect. Julius, Jared, do you have other stuff? I think that we could probably, I benefit from your insight with any of this. So.
No, that was the main point on those ones. The other thing and you can confirm as you're the expert with Abbott, but the one thing I do like about your devices is with your cap confirm is instead of having the auto threshold at double the output, yours works almost on a beat to beat. Is that correct?
Yeah, correct. So
you place like 0.25 above threshold, but if you don't get it, if there's no evoked potential after the spike, then you hit with a 5-volt output as a backup pulse.
Correct. Yes. So that's how that's how our system works for auto capture. If you're talking about BIVs, if you look at like LV cap confirm or RV cap confirm, those are not beat by beat. Those run on a cycle. And that's why you see a higher margin. But with auto capture, it's just 0.25 volts over the threshold. And that's just to ensure it. And then it has a backup pace. One thing to remember though, however, is the backup pulse is unipolar. So if you have like an electrically isolated can, which you may not see a lot of, but sometimes the patient have allergies, they'll insulate the can. Or if you have issues with unipolar pacing, that backup pulse could cause trouble. For example, unipolar pacing can cause pocket stimulation or stimulate the can. So the patient actually feels that in their chest. So.
So I was going to say for Medtronic, obviously Medtronic has got like an adaptive, the auto capture management and auto sensing that it's called adaptive management. The other thing to bear in mind, if say for instance you're having like a higher threshold, or since after implant, and you want to put adaptive on, because you don't know it might keep creeping up and things. I know that with Boston, if you do put that capture management on, it does have a limit of like V output, so it won't go any higher than 5 volts. Mm-hmm. So you could run into trouble with that. I think Medtronic is a little bit higher than that. Whereas if you were putting it on manually, you can certainly put it to about 7.5, output and that. So with Boston, there are limitations of that. I think Medtronic is a little bit higher than that. So we have been caught out before in the past when somebody's having like the threshold is creeping up and you prove, which is sensible to put adaptive or capture management on, because it could, it does auto threshold checks and then it's just accordingly. But there are limits. So for instance, if the lead ends up if the threshold ends up being really high, about 5 or 6, then you could run into trouble. If the patient has got complete heart block or something.
Yeah, that's a good point. Abbott goes to 5 as well, just so you know, 5 volts. So yeah, I think they're great because as you said, it can give you a trend over time. But if their threshold is getting up there, if it's already at 4, then you may want to turn auto capture off and give yourself a nice 2-to-1 and obviously schedule them for some sort of lead revision eventually, because that's going to wear the battery out quickly. One thing too that I want to mention with Abbott's auto capture, and I'm sure with the other devices, is they can be tricked with fusion. So we talked in previous weeks about fusion and pseudo fusion when you're pacing into an intrinsic event and you either contribute to the pacing or it doesn't really do anything. The device using its auto capture algorithms is looking at what the evoked response is from the pacing spike to the actual, evoked response of the tissue. And if you're fusing, that can change the morphology of the wave. So patients with AFib with RVR or a lot of PVCs, it can no longer determine, well, this is what capture looks like. It may think it's not capturing and it will go to a high output, which means that it'll just go ahead and start pacing its backup pulse here at 5 volts, unipolar. So a patient that could have a threshold of 0.5 volts at 0.5 milliseconds may be pacing all the time at 5 volts, prematurely wearing down the battery because we're trying to make auto capture work when it doesn't work for this patient. In those cases, just set a nice fixed output. So.
Yeah, AJ.
Yes, sir.
Yeah. So let's go to the passive lead and active lead.
Okay.
Good. So because here we plant more of active lead here. I think about 98% of our implants here are active leads. So one of the things that we also observe in our implant here is for the active leads, once you rotate the tip of that body of the leads and the screw comes out at the end into the myocardium, that screw does not move further again. So the risk of perforating the myocardium in the new technology is very, very low. But if you rotate it several times, because once it comes out, I can show you, I have a lead here. Yeah, once it comes out, you can see it here. I don't know whether you can see my hand. Okay, good.
Let's see.
Yeah, you can see my hand. Am I right? Good. Yep. So once this lead once it comes out, it doesn't move further from that point. So rotating it several times means that that screw is going to be turning within that segment where it pierces the myocardium. And it has
Oh, looks like we may have lost you for a second here. So I'm going to give him a little bit more time. I'm not sure if everyone else can hear me. Is anyone else in the line still, or do we lose everybody?
I'm here, mate.
Okay.
No. Yeah.
Okay. We'll wait for him to come back. But for those in the line, what he's talking about is essentially the screw here comes out. So you make contact with the tissue itself, and then you will then exercise, or you'll then extend the helix into the tissue. For St. Jude devices, we generally look for a nice W shape on fluoroscopy to indicate that you put the screw out enough. If you screw it out too far, though, you run the risk of having microperfs, which are obviously not ideal for the patient. I don't know, Jared, Julius, what are your general, what do you look for a Medtronic lead when you're putting it out?
Yeah, especially with Medtronic, they have little markers that are seen under fluoroscopy. So what we usually typically do is just zoom in with X-ray, and you can see you can see the radio peg markers close up. So then your helix is fully extracted. So at that point is when you stop rotating the helix. I know with Boston leads, they have a little different, because obviously a lot of the other leads is you deploy the helix, but in some of the Boston leads, I know you actually have to rotate the actual whole lead to the helix is actually out already. And it's got a covered tip on it. So when it hits the myocardium, the blood, it dissolves or something, and then you actually physically rotate the whole lead to migrate it. So just something a little different, but something to look out for as well.
Yeah. So what he was referring to, sorry, Julius, I don't know if you're jumping in, but what like a Boston sweet tip lead, it has like a sugar or polysaccharide in the front on the tip that kind of isolates the helix as you're moving through the vasculature, because you don't want to have this traumatic sharp helix out. It'll just get caught on everything. So you get it inside the ventricle, and then it dissolves after a minute or two, and then you're able to actually screw it into the tissue without it getting stuck up here when you're in the SVC region.
Okay. So AJ, have you answered it? Yeah, have you explained it?
I'm not sure exactly where you're going with that, so I was going to wait till you came back.
Oh, so what I was saying is that this active lead you see here, this is the active lead.
Let me see if I can find you. There you are.
This is the active lead. Once this lead is rotated and it comes out, it doesn't move further. any longer. So the risk of piercing through the myocardium is reduced in the latest technology. I don't know that, or I don't know whether the same thing with St. Jude and Boston, but this is what is specific to what we see in the Medtronic leads. Once it comes out, it doesn't move further. But I think it's the same with all the company leads for the active leads. So the issue is that once it comes out, there is no need of further turning because it will rotate at the same point. The second thing is you talk about the current of injury. Are you looking for the positive deflection, or you are looking for negative deflection, or for both?
So negative is an indicator that you could possibly have perfed. So in general, you don't want to see negative. There are specific instances where the lead could be laying against the septum. And if you think about the depolarization of the heart, I'm going to move you here. If you think about the depolarization of the heart, you have it moves from the septum to the rest of to the apex and then to the free wall here. So if your lead is kind of sitting on the septum like that, then you could possibly see a negative deflection. It's possible. It's less likely. It's more likely to see in like what are they called? Leadless devices. But if you're laying against the septum, it's possible. But in general, if you see a negative injury current, that's a strong indicator that you need to take a closer look at this lead. Obviously, these leads are not very big. So the risk with perf is a lot less than, say, a leadless, but in general, you still need to attend to it and then possibly even do an echo to make sure. But yeah, you want to see QRS widening and then also ST elevation with your injury currents.
All right. Good. Yeah. Now, my next comment.
Sorry, Dr. Daffy. I was going to your first question, like for implanters with Medtronic, or I think with any of the manufacturers, when you're turning the screw on, when you're deploying the helix, because there's a latency in the torque, you have to make sure that you take your time, especially with Medtronic or Boston, like, one, rotate, two, and you wait for the force, the torque to spread through, because sometimes it's possible to overdo it. And you might end up jamming like the screw mechanism and things. So there is a latency in the torque. So you just give it time, one, and you wait, two, very, very slowly. And that seems to help.
You are right. Yeah, correct.
And depending on how...
The next question is on the issue of the blanking. Sometimes we put it in partial plus. AJ, what is the difference between these two?
I'm sorry, you said the difference with blanking is you put it in what, sorry?
Partial and partial plus.
Partial, that's Medtronic.
Yes.
Yeah.
I'll go ahead and let you
to explain.
Yeah, that'd be great.
Again, that's Medtronic's PVAP. So Medtronic normally have like an absolute blanking period of about, I think, 30 milliseconds. And then partial will add an additional 150 milliseconds on top, where basically it will blank anything back. So based on sensitivity that you've set it up. So for instance, if you're seeing a far-field R wave on the atrial channel, and if it's in partial, and you're still seeing it, the difference between partial and partial plus is that partial plus also adds an additional 150 milliseconds blanking period, but the partial plus will automatically adjust the sensitivity and decrease it. So you're less likely to see any far-field R wave over sensing on the atrial. But at the same time, both of them will add any atrial tachyarrhythmia that comes up and add it to the bin, like the counter, if you like, so that if there is any AF or atrial tachy, in the atrial channel, it will basically, if it needs to appropriately mode switch, it will do that. So the difference between partial and partial plus is partial plus will have the same blanking period interval, but it will basically it will auto decrease the sensitivity, and that's so that you don't see like far-field hours and things like that. So that's a Medtronic.
Okay. Okay.
So
what algorithm is St. Jude's? What algorithm is St. Jude's cover for the partial plus and partial? AJ.
So St. Jude, basically, you have your standard PVARP, and then you'll have like PMT prevention algorithms. So if you're talking about like preventing PMT, it'll have like an A pace on PVC, where when a PVC occurs, the device will basically withhold, it'll avoid atrially tracking, and then it will atrially pace to regain control of the atrium, and then it will restart the cycle. So basically what it's doing is it's saying like, ignore after a PVC, ignore what could be happening in the atrium, wait 330 milliseconds, and then atrially pace to regain control of the atrium and restart the cycle to try to keep a PMT from ever occurring. And then with PMT, there's different algorithms to basically determine by doing wiggle tests. I could really get into the weeds here with this, but in general, just different ways that the companies have found to avoid causing PMT. When you talk about absolute blanking, there are, I think we kind of talked about this. I don't know, maybe Elvis, maybe this was you and I when we were talking about it the other day, studying for the IBHRE, but the devices have basically looking for crosstalk detection windows and things like that as well to avoid any kind of crosstalk and inhibition. And that's more of the PVAB side of things, which would be absolute blanking.
Thank you, sir.
Well,
okay.
Yeah, I think one of the key take-home messages, especially when it comes to programming, is that, yeah, as AJ said before, is making sure that you're not, if you are seeing some far field R waves or something like that on the atrial channel, is your first thing should not be increasing PVABs and PVARPs immediately. I personally always try to change sensitivity where I possibly can. Because a bit like with an ICD, if you start putting your PVABs out and your PVARPs way out, then as you go into maybe sinus, high rate exercise, then you may end up blanking actually appropriate sinus beats. So it's important to use sensitivity first when trying to get rid of far field R waves and not necessarily blanking.
Yeah, that's
a good point. But so Medtronic, obviously, Jared, they've got partial and partial plus as a already preset values, and they obviously both of them work that you won't if there are any atrial tachyarrhythmias, they will actually detect them and add them to the counter so that it will not inhibit any and bring on any inappropriate mode switch. It will appropriately mode switch if it needs to. The only thing I will say about partial plus and I think nominally Medtronic have partial on, but if you don't see any far field light, what Jara is saying, always look to see if you can actually change the sensitivity first. And if not, then obviously you can program on partial plus, but the algorithm does consume more battery though. So obviously bear that in mind as well. And that, so yeah.
Okay, so AJ, let me give an example of something that happened that was a week ago. We did a dual chamber pacemaker, and this patient, as at the time of implant, the thresholds were all fine. Ventricular threshold, we got 0.7. Atrial threshold was around 0.6. But I did that programming with Mr. Julius. But on a few days after the implant, I felt that the man was excessively moving that hand. You will instruct him, put him on on hamstring, but on his own, he does what he wants to do. So when we came back to look at the programming, we noticed that there was a warning of high ventricular threshold. So I did the programming with Julius, and we tried to see what happened, but I knew that we are already likely going to go back to reposition that lead. So Julius is here. It showed me so many things to do, and we did it because when you showed that high ventricular threshold, a device that's supposed to have 10.5 years, you will now see around 5 years. And I don't really like those things. African patients are people that you must satisfy when they come to you the first time. And so I knew that this thing may likely land us again into repositioning. So I gave this man 3 days to return back. He returned back on the 3rd day. I looked at it again. You see that the amplitude that was set at 3.5 has gone back to 5. And the warning appeared again. So at that point, I did not call Julius. I just told the man, we are going to reposition your ventricular lead. So we went back, opened up again, and repositioned the ventricular lead. It took us about 20 minutes because we opened up, took a stylet into the ventricular lead, unscrew it, then reposition it, and close back again. So now after that, everything went on fine. So what could you have done, AJ? And Julius is here. After the repositioning, I call him, and we interrogate the device, and everything is fine.
Okay, so what would you have done before revising, do you mean? Or what would you have done? I think you and Julius made the right call that revising, but I think there's a number of things you would address first is, are you able to get a chest x-ray and see if the lead is visibly moved? Because
correct.
Okay.
Correct. That is a good question, man, sir. What we did, I took him into the cath lab, the first thing before, because we have the image, the final image as at the time of, after the first device closure, we have the final image. So we looked at it, still in the cath lab, we looked at it. Then we took another image before the opener and noticed that that device has shifted. And note that ventricular lead has shifted. Yes. So we did that.
Okay. I mean, if your threshold's not great and the lead is clearly moved acutely, I would say, a revision is probably in order. I'm sure. I mean, Jared, I think your input would be great here too, since you have experience. But I mean, if you're not capturing well, it's obviously in a different location, then you may need to just go in and revise it while you still can, as opposed to waiting for tissue ingrowth and things like that.
Yeah.
Yeah, I totally agree, AJ. I think you're right, Dr.
Julius and Mr. Gerard.
Hello, sir.
Yes, sir.
I think you're right. I don't think this was an operator thing. It sounded like, as you said, the patient probably moving his arm too much caused a micro displacement of the lead. And the helix has just come back just that little bit, enough to increase the threshold. And there's nothing else you can do other than go back in, unfortunately.
All right.
Just for our own knowledge, where do you typically place your ventricular lead? Do you go for like more of an apical placement, or do you go like mid to high septum, or?
No, it's more of apical. If I don't get good sensing and threshold at the apical, then I go for septum. But the first thing is apical. Then also on the echo, before I do all my cases, I usually do echo for them, look at the apex, see how thick the apex is. All this also helped me to go for the apical at once. But once I go for the apical, if I don't have good sensing and good threshold, then I start looking out for the septum. Okay. And if I get that at the septum, I move on and screw it and move on.
Jared, Julius, do you typically see that as well as apical placement? I know that for pacemakers, we've moved. A lot of people will go more mid-septal, and then for like defibrillators, they'll tend to go more apical, so you have good inferior coil placement.
Yeah,
that's what we do.
Yeah, we have a consultant who AJ. I'm hoping that he will come on for the leadless pacemaker talk, the one I was speaking to you about. And I think Dr. Duffy knows him, Dr. Sharman, and he doesn't like our waves that are less than 10 millivolts. So he tends to like to reposition and things. But I think typically, just like you said, mid septum, low septum, and then he would do. Obviously, it depends on if it's a young patient. He does really try. Somebody who is not going to be pacing a lot, he does actually really try to go for septum as much as he can. Somebody who's going to be pacing a lot, obviously we have Voights going RV Apex and that, but you know, so he horses for courses, as it were. But yeah, we do a lot of septal implants. Yeah, he does a lot of septal implants. But with ICDs, yeah. Most of the ICD patients are not sort of pacing indicated. So yeah, we tend to go for RV Apex and things like that. I mean, there's a difference, isn't it, between like DFT, correct me if I'm wrong, like Jared and AJ, with DFTs, if RV Apex is preferred to RV septum, like if it's mid or high septum position in terms of like, you know, DFT, shock pathway defibrillator and that. What do you think with ICDs?
Yeah, I don't know. I'm not sure about what it does to DFT, whether you're in the apex or the septum. I mean, obviously, if you're septum, it maybe changes the position of the RV coil. But as the shock vectors are coming from the coils, I'm not aware of apical versus septum, what it does to a DFT threshold, unfortunately. But
okay,
just to touch on the points of putting the lead in the RV apex or the septum, I mean, as you say, there's pros and cons for both. I think if you can go septum, obviously the idea, especially in someone with heart block, you're going to ideally get a nicer narrow QRS complex as it follows the conduction system a little bit better. Obviously the apex, in ideal world, it's going to be a lot thicker, so less perforation risk. You've got a lot more stability in the apex perhaps than you are on the septum, as gravity pulls the lead down a little bit more on the septum. So pros and cons to both, I think.
Yeah, I think so. You both made very good points. Yeah, I really can't speak to any knowledge as far as DFTs, but yeah, I agree. You tend to have more, apical, you tend to have more stability versus up here, you're kind of hanging on the mid septum. But so we're going to be talking about this probably a little more when we talk about leadless pacemaker implants, but in researching leadless, I think that you can actually learn quite a bit about RV anatomy and lead placement. So there's been some studies basically that show good safe placement, especially of leadless, but any kind of device. So if you're looking at like an RAO here, I don't know why I bother writing these out, but in general, when you're placing a lead or a leadless device, up here, your anterior groove of your heart, your inferior groove of your heart, and your apex are all pretty dangerous spots because you're getting away from the thicker tissue of the septum and you're getting to more either the lateral tissue or like this transitionary tissue where the RV connects to the septum. So when you're looking in RAO, your lead placement, ideal spots if you're going more apical, especially for like leadless, for example, is right around here. You're safe all the way around, all across here, but then you worry about valve interaction, right? Because you're valve. When you're looking at LAO, this is a terrible LAO view, but SVC, IVC, LV, your left ventricle is going to be more dominant structure versus your RV is going to be more of a crescent shape. You want to see a foreshortened view of your lead. And then ideally, if you're coming from a superior axis, you kind of want to use these radians as an indicator of lead placement here, right? So if you look and your lead is pointing straight that way, it's probably placing itself straight into the septum, right? Because this is your septal wall between the right ventricle and left ventricle. If you're looking at it and the lead is kind of facing down at an angle here, so you're going down like this, it's probably still septally oriented. And as long as you're not placing the lead out here, you're probably not in the apex. So this is all like your apical area. So you're looking at your RAO space to determine your ventricular space, and you're kind of aiming for a sweet spot around here. You're looking at LV and these radians to determine the actual lead placement. And then if you're looking at it in LAO and it's facing like this, that means that your lead could very well be any kind of free wall orientation. So I know this is kind of like off topic of the subject, but you kind of got me interested when you're talking about like lead placement and orientation. So just things to look at. I always recommend looking at the lead in RAO just to determine that you're not in these danger zones and you're well within nice right ventricular space. And then looking at an LAO to determine whether or not you're septally oriented. Most of these leads have about a 2 millimeter helix, and they're pretty small French size. So if you were anterior, it may not be the end of the world if you were on the free wall or the thinner tissue of the heart. But there's still a higher perf risk, still higher micro perf risk. So always take that account. And if you can, septally place it, even if you're apical, you still want to make sure that you're against like the nice thick tissue as opposed to this thinner tissue out here. That makes sense.
Yeah, it makes sense.
Jared, Julius, do you have anything else you want to add?
No, that was perfect. I thought that was really good.
Yeah, that was nice, mate. Look forward to the leadless talk, actually.
Yeah.
I'll be honest. So I've been studying leadless for about 1.5 years now as we go through our launch, and it has made me a lot better at understanding like the right ventricular space and made me a better implanter in general. I would say, not implanter, but rep. So I'm excited for you all to see it. And there's some really cool studies like this radian one. I'll see if I can actually find the study itself, but it basically just talks about lead placement based upon the degree. Obviously, if you're going from an inferior approach, you're looking at the opposite. But cool. Well, I appreciate you, everyone, jumping on this call. Sorry, I kind of bumbled my way through the first half of the call, but I'm glad we got there in the end. And yeah, if you have any questions, reach out to me, reach out to any of our other friends here. We're all here to help support and build these programs. So let us know how we can help.
Excellent. Well, thanks, Gerard. Thanks, AJ, rather. Sorry. Thanks, Gerard, as well. Thanks, Gerard.
Yeah,
Thanks, AJ. Thanks, Gerard.
Thanks, AJ. Thanks,
Thank you,
Gerard.
Doctor.
Yeah, thank you.